Thank you, Dr. Hisham, for this excellent webinars. I hope it will be very successful, inshallah, bismillah, and all the candidates will achieve very good knowledge and experience from these webinars. And also, I would like to thank the panelists for this excellent presentation from significant radiological professors. Thank you very much. Today, I will talk about an issue which is important for the gynecologist and the infertile ladies. I will talk about the as a basic foundation or basic layout for the use of ultrasound in infertility. Evaluation of infertile women should be conducted in a systematic, rapid, cost-effective manner with least invasive methods for detection of the most common causes of infertility. Actually, we have a lot of tools to diagnose infertility: histolbingiography, endoscopy, either hysteroscopy or laparoscopy, lab, MRI, a lot of tools. But ultrasound now has a vital role in diagnosis and management of infertility. No gynecological clinic without an ultrasound machine. Its regular use minimizes needs for other investigations. So it is a very important tool that we have to know well and how to use it in different aspects of management of infertility from the gynecological point of view. It helps us to diagnose the etiology, either in the uterus, in the ovaries, in the tube, or in the pelvis. Also, it could be used a good tool for treatment of infertility. We use it in IVF, either in the retrieval of the oocyte, it is ultrasonic guided, or in the embryo transfer, which is ultrasonic guided embryo transfer, or aspiration of ovarian cyst or hydrocelebrities during the course of the treatment of infertility. So, as a diagnosis, regarding the uterus, it can assess the size, the position, the shape, the endometrium, either its thickness or its pattern. Also, it can diagnose the abnormalities as the anomalies, and I will not talk about it because Dr. Nermeen gave it in full details. The diagnosis of fibroid, adenomyosis, presence of adhesions or polyps. And also can be used in the treatment during the IVF through embryo transfer. As regarding the ovaries, it used for assessment of the position of the ovary, its mobility, volume, enteral follicle count, monitoring of the follicular growth. And in diagnosis of polycystic ovarian, sonographic picture of polycystic ovarian disease, the presence of ovarian cysts or tumors. And also can be used during the course as oocyte retrieval, as I will show you in a small video later on. The tube, the fallopian tube, could diagnose the patency or diagnose the presence of hydrocelebrities. In the pelvis, the presence of free fluid or masses in the pelvis. This is the panorama for the use of the ultrasound. And usually we use the fundamental use of ultrasound if mostly from day 8 to day 12, but also I can use very early in the menstrual cycle to assess the availability or the ovaries is accessible before the IVF and for the enteral follicle count. So for uterine factor, assessment of the size, shape, and the position, and the endometrial sickness, and also the anomalies as I told. Actually, assessment of the endometrial sickness, it is very important for us as a gynecologist. I am not allowed to transfer embryos in IVF if the endometrial sickness is less below 8 millimeters. And also, the endometrial pattern is very essential for us before continuing the IVF cycle. And most of us use ultrasound as a tool now for the follow-up. Previously, we was acquainted by the use of the lab in as associated with the ultrasonic follow-up. I measured the progesterone on the day of the oocyte retrieval, but now we don't do that. We are depending on the endometrial pattern, this nice triple line. But if I find there is increased hyperechogenicity of the basal layer of this line, I may order progesterone to check for the premature elevation of the progesterone. Because if it is above 2 nanogram per ml, I will not transfer the embryos at this month. This picture shows the total secretory pattern of the total hyperechogenicity, which occurred after the HG administration or after ovulation. And if I found this picture before the HG administration, so I suggest that there is a premature progesterone rise. As uterine anomalies, I will skip it because Dr. Nermeen talked about it in full details. So, as regarding fibroid is a rounded stinged masses with echogenicity either increased, decreased, or similar to that of the myometrium with uterine enlargement. According to the FIGO, International Federation of Obstetrics and Gynecology, it goes a classification for the presence of the myoma. Either it is 0, which is a pedunculated, 0, which is a pedunculated intracavitary. 1 with when there is more than 50% of the myoma are present inside the uterine cavity. 2, when there is less than 50% of the myoma outside the inside the uterine cavity. 3, which is, yes, it is outside the uterine cavity, but it contacts the endometrium. It is 100% intramural, but it just contacts the endometrium. 4, which is intramural but not direct contact with the endometrium. And then from 5 to 7, this is the subserous one with a different percentage. And there is a significant one, which is the hybrid one, which passes from the 2 to 5. It is present less than 50% in the endometrium, in the endometrial cavity, to less than 50% in the serosal cavity. And actually, we have to know the different modalities of the ultrasound that can give you a different picture of the myoma. If you look to this 2D, yes, there is a myoma here, and it is encroaching on the endometrial cavity, I think more than 50%. So I consider this is grade 1 fibroid. But if I go for 3D ultrasound, I will find that the myoma is less than 50%. So it is grade 2. It is the same patient. So it is less than grade, it is grade 2 myoma. If I shift to sonohysterography, yeah, it will show now that it is a grade 3 myoma. It is 100% intramural, but it is only touching the endometrium. So don't depend on a single modality for the use of the ultrasound, because there is a great difference now between the 2D and the use of the sonohysterography for confirmation of the site of the myoma. Sometimes the myoma may appear as a pedunculated endocavitary fibroid coming from the cervical canal in like this picture, in which show internal echogenicity similar to that of the myometrium, and is pedunculated coming through the cervical canal. One of the important diseases that we face a lot during infertility, especially in the woman above 40, the presence of adenomyosis, which could be diagnosed easily with the use of ultrasound, in which there is a globular uterine enlargement with the presence of subendometrial glands and asymmetric enlargement of the uterus, mainly in the posterior, mostly in the posterior wall, with a lot of heterogeneity in the endometrium and poor definition on the endomyometrial junction. And if we apply Doppler ultrasound for the adenomyosis, we can differentiate it from, especially the localized adenomyosis, from the fibroid, because the fibroid takes its blood supply from the periphery. So in fibroid, I will find all the vasculature mostly at the periphery. But in adenomyosis, there is a diffuse vascularity all over the lesion. Evaluation of the endometrium is one of the important steps, as I told you, in the endometrial pattern. To diagnose Asherman syndrome, best seen in the pre-ovulatory phase. I found a thin endometrium, not corresponding to the time of the cycle, and mostly it is echogenic, hyper-echogenic, white in color. And there is irregular refractive foci inside the uterine cavity, and there is interruption of the uniformity of the midline echo of the endometrium. Also, ultrasound could diagnose easily the presence of submucous or endometrial polyps, and we can identify also its in different sites and its feeding vessel. And sonohysterography identify it easily inside the uterine cavity and determine its site to help me for its excision through hysteroscopy. And this shows the feeding vessel for the polyp. So this is an overview for what I want to know about the uterus while I'm preparing my patient for treatment and diagnosis of infertility. Shifting for the ovarian factor, assessment of the ovary, either its volume, position, accessibility. Accessibility is very, very essential, especially in IVF. Most of doctors come to you if they are not expert in the IVF, and now you know that most of the gynecologist wants to know to work in this field and start to stimulate or giving ovarian stimulation for the patient. And during the follow-up, he find that the ovary has an adhesions and it is up, not in the pelvis, because he didn't evaluate the accessibility of the ovary before starting of the stimulation, and also of the presence of adhesion around. Enteral follicle count, it is very essential to determine the ovarian reserve and to know and expect the response of this patient to the ovarian stimulation. And it comes hand to hand with the anti-Mullerian hormone, which reflect also for the ovarian reserve. But most of us depend on the enteral follicle count for diagnosis of ovarian reserve because it is cheap and it is accurate. And also use the ultrasound for follow-up of the follicular growth. Ultrasound could be used, as I told you before, for diagnosis of anovulation, diagnosis of the picture of the polycystic ovarian disease, diagnosis of presence of ovarian cyst, hemorrhagic cyst, endometriomas, and the dermoids. This is the normal appearance of the ovary with a size 3 to 1 centimeter and presence of enteral follicle count of more than 6 in both ovaries. And this is the pre-ovulatory follicle with the presence of the dominant follicle, which ideal size from 18 to 20 millimeter from the inner dimensions. And this is a typical picture of the corpus luteum with a thick wall and fibrin network inside. And this, the enteral follicle count, we measure it basal at the 2nd or 3rd or 4th day of the menstrual cycle. I count all the enteral follicle from 2 to 10 millimeter, and this ovary contains 9 enteral follicles. This ovary contain very few enteral follicles. They contain only 1, and this containing only 2 enteral follicle. And this contain a lot of enteral follicles, suggesting that this patient may have a picture of polycystic ovarian disease. This is a typical picture of the endometrioma with a ground glass appearance with several hyperechoic mural foci in it. This is an overview picture for the ovaries. Then we'll shift for the tube. Tubal patency hycosi or sonohysterography as an alternative for the hysterosalpingography. Actually, hysterosalpingography is the gold standard for diagnosis of the tubal patency because it is documented. It can show easily the site of the obstruction, and also it can give us a little bit about the presence of the peritubal adhesion. But hycosi and sonohysterography also could provide us some information about the tubal patency. Diagnosis of hydrosalpinx is essential because it interferes and decreases the implantation, especially with IVF. Hydrosalpinx appear as a sausage-shaped structure tapered near the uterine origin. It has a thin wall with multiple and incomplete septa, and mostly absence of peristalsis to differentiate it from intestine. IVF, the use of ultrasound in IVF, and also aspiration of ovarian cyst and hydrosalpinx. In IVF, we use ultrasound basal before IVF cycle to evaluate the position with size and cervical direction of the uterus to exclude the presence of fibroids or polyp. And in the ovaries, the first important thing is the accessibility of the ovary, and then its volume to diagnose also polycystic ovarian disease, because this will determine the protocols of stimulation. Because if we are going to stimulate the ovary hardly in polycystic, it may have ovarian hyperstimulation syndrome, which is a very dangerous and very life-threatening condition. Also, the presence of ovarian cyst before the start of the IVF cycle. Diagnosis of hydrosalpinx is essential, and I have to deal with it before the start of the IVF cycle. So ultrasound helped me a lot in diagnosis of this important pathology. Controlled ovarian stimulation. Ultrasound used during the controlled ovarian stimulation by confirming the down regulation after I start the agonist, and this by diagnosis of the thin endometrium less than 6 millimeter, quiescent ovaries containing only small follicles, not more than 15 millimeter size follicles, and also follow-up of the follicular development and the measurement of the endometrial thickness and showing the endometrial pattern, as I told you in the start of the lecture, not discriminating the pattern. There is no basal hyperechogenicity in the endometrium. Follow-up starting from the day 6 stimulation of the ovaries, of the protocols, and repeated every other day depending on the response of the patient. I mean, I need to follow up the patient daily, especially in antagonist protocol, because of the high incidence of premature LH surge. Monitoring of the ovarian stimulation, as I told you, every other day. Then the procedure that I do it for the IVF is the egg collection through introducing the vaginal ultrasound. You know that the egg collection started in 1978 by Edward and Steptoe, in which they used the laparoscopy for retrieval of the oocyte. And then this developed by the development of the ultrasound. They started to use the abdominal ultrasound, and filling the bladder and introducing the needle transvesical, so it is transabdominal, transvesical, to reach the ovary to aspirate the content. And then they try to introduce the needle through the vagina and following it through the abdomen by abdominal ultrasound, which needs a high level of coordination. And then after the development and the appearance of the vaginal ultrasound, it becomes the standard route now for the egg collection, in which we introduce the needle on the top of the vaginal probe through a needle guide, and it will appear like this with some trick of use. It doesn't work. Okay, the video doesn't work. The video here, I want to show to you that the needle is introduced. I will work on it. The needle is introduced through the follicle, and I will keep the needle all the time at the lower third of the follicle to help to aspirate the whole content of the follicle. There is an important guidelines here during the egg collection using the ultrasound probe, not to move the probe at all while the needle is inside the ovary, because this will cause a lot of bleeding. You have to withdraw the needle to the edge of the ovary before moving the probe to shift to other follicle. And also ultrasound used for ultrasound guided embryo transfer. We introduce the catheter inside the uterus under guidance of the ultrasound, and then putting the embryos just below the mid cavity of the uterus. So ultrasound helped me a lot to put the embryos in the proper site that gives the highest pregnancy rate. Aspiration of ovarian cysts is an easy procedure, can be done in outpatient clinic even without anesthesia. If there is a residual cyst more than 3 centimeters, that may affect the ovarian response in the stimulated cycle of the IVF. So through the vaginal probe, I introduce the needle in the ovary. It is like a syringe and aspirating the ovarian cyst. Ultrasound provides systematic, rapid, and cost-effective tool for diagnosis of most common causes of infertility, and also used as a therapeutic machine, helped me in the IVF for egg collection, for embryo transfer, and also for aspiration of ovarian cysts.